In this episode, we will begin our discussion of chronic scrotal symptoms with focusing on non-neoplastic conditions. Remember that in the previous episodes we discussed the causes of acute scrotal symptoms, including scrotal pain and swelling, with focusing on the two initial rule-out emergencies, the most important not to miss differential being torsion, followed by testicular trauma, and then we discussed the acute testicular pain in the episode dedicated to epididymitis or orchitis, with its differentials being inguinal hernia and Fournier's gangrene. In this episode, we begin our discussion of chronic scrotal symptoms by categorizing them into neoplastic and non-neoplastic ones, and the non-neoplastic ones would be the ones that involve the spermatic cord versus the ones that involve epididymis. In the next episode, we will discuss the masses involving testis. Now, the first question is, what elements could be the source of a scrotal mass? Well, in addition to the testicular masses that we will discuss in the neoplastic episode, we have the masses that arise from spermatic cord and then the masses that arise from epididymis. What are the masses that are originating from the spermatic cord? They include varicocele, hydrocele, and hematocele. Now, what are the masses that originate from epididymis? They include epididymal cyst, spermatocele, and torsion of epididymal appendage. Please don't confuse this one, the epididymal torsion, with the testicular torsion. The way we can memorize this are the 3 C's for the spermatic cord. That's seals, varicocele, hydrocele, and hematocele, and then TCS for the ones involving epididymis, and they include epididymal cyst and spermatocele and torsion. That's TCS, torsion, cyst, spermatocele. Okay, talking about the masses involving the spermatic cord, the first one is varicocele. So what are the clinical findings associated with varicocele? It could be asymptomatic or associated with dull pain and sense of heaviness. A mass that resembles a bag of worm may gradually appear protruding on the scrotum, and on physical exam it may show enlargement with Valsalva maneuver. Remember, if these findings are ignored, the patient may present with infertility. Now, what are the two types of varicocele? We have primary versus secondary. How we differentiate these two types? The primary type usually has the onset at puberty, is left-sided, is more common, and it has the typical finding of decompression when supine. The secondary type can be right-sided, could have an earlier onset, that's prepubertal onset, and most importantly, it persists in supine positioning. Now, what is the pathophysiology of the left-sided or primary type? The left gonadal vein that drains into the left renal vein can be compressed between supramesenteric artery and aorta, in addition to having a longer path. While the right-sided one would not commonly get this issue unless if we have a retroperitoneal tumor impinging on the IVC and causing the impaired drainage of the right gonadal vein. Based on this knowledge, what is the assessment and planning for the left-sided or primary versus right-sided varicocele? Remember that first and foremost, all patients after initial physical exam and Valsalva maneuver require an initial semen analysis. However, if we are dealing with a left-sided pubertally initiated case, which could be symptomatic or asymptomatic, depending on certain variables, we may decide just observant management and reassurance. So once more, what are the most important factors determining the course of management? One is presence or absence of warning signs. That is the ones that may indicate possibility of a mass. Two is if there is no warning sign, we consider age, presence or absence of bothering symptoms, and the results of semen analysis in combination with the patient's desire for future fertility. So once more, the first step is clinical assessment to evaluate presence or absence of warning signs. What are they once more? If it is right-sided, or if it is initiated pre-pubertally, or if we have a rapid growth in a unilateral varicocele. These are the warning signs. These mean we need to perform what? We need to perform imaging. More on imaging in a second. Okay, if the patient does not have any of these warning signs, that is an asymptomatic, slowly growing, left-sided, that does not bother the patient, what is the course of management? Semen analysis, and if everything sounds normal, that is the normal semen analysis, and in combination with desire for fertility, or even abnormal semen analysis in a patient who does not desire fertility and does not have any symptoms, in that situation and only in that situation we can move on with observant management. What does this mean? It means if the patient has asymptomatic left-sided varicocele that does not bother the patient, and patient does not desire future fertility, we may not even bother doing any imaging studies. Once more, you need to know that diagnosis of varicocele is a clinical diagnosis, but ultrasound or more imaging studies are required per their precise indications. Now, the indication is what exactly? As I mentioned, presence of warning signs. Now, if the warning signs are present, what's the course? We have taken care of the semen analysis for all patients. If the warning sign of a secondary type varicocele is present, we prefer performing a CT, abdominal CT. And why is it so? Because we need to rule out the possibility of retroperitoneal tumors, and CT is a superior imaging modality as compared to the alternative, which is what? Of course, ultrasound. So again, remember, anything that hints in favor of a right-sided or tumor, such as no decompression, prepubertal onset, unilateral right-sided, these are all indications of CT. Ultrasound is an alternative. Now, what are the possible ultrasound findings for varicocele, either right side or left side? Well, we have the possibility of retrograde venous flow in the pampiniform plexus. Do you remember what was the venous flow in torsion? In torsion, the venous flow was absent. Here, the venous flow is retrograde. Don't confuse these two. The second finding is reported as a mass which is anechoic adjacent to the testis. And adjacent to testis, we have anechoic tubular mass. By the way, do you remember what was the findings possible in torsion, especially the long-lasting torsion? That necrosis in torsion could manifest as heterogeneous echogenicities, not anechoic. The torsion, necrosis of testicular torsion manifests as echogenicity, but varicocele is anechoic. And of course, the other finding is the reported dilation of pampiniform plexus of veins. Now, we talked about the indications for imaging. Now, what are the indications for an intervention? That is usually surgical correction. This is the management of the varicocele itself. We are not talking about the etiologic management. Like, for example, if CT shows a retroperitoneal tumor, we manage it surgically in a different surgical consult and management. I'm talking about the conditions in which, for example, the patient has symptoms or has some impairment of sperm functionality in sperm analysis, in semen analysis, and therefore the patient needs intervention. So what are these indications? Again, if the patient is young, usually these are the patients who prefer normalization of their sperm indices for future fertility. If there is a risk of testicular atrophy, and again, if there is poor sperm quality in semen analysis. These are indications that the patient needs intervention. Please, however, combine these with patient's preference, in specific in terms of presence or absence of bothering symptoms, and presence or absence of a desire for future fertility. Now, if the patient does not have a desire or an indication for any of these interventions, what is the management? We follow up with semen analysis every 1 to 2 years. And again, this is our most asymptomatic patient with normal initial semen analysis, who is most likely older than 21 years. These patients, the only management that's required is follow-up semen analysis every 1 to 2 years. So once more, can you tell us what are the indications for semen analysis in a patient with possibility of varicocele? For all patients, regardless of primary or secondary type, at the beginning of the management, and also for the patients who do not have any indication for interventions, we perform semen analysis for follow-up every 1 to 2 years. Now, what is the surgical approach? It's gonadal vein ligation. Do we have any scenario that could be in between? Yes, we could have, for example, a symptomatic patient, a patient who has symptoms, who does not desire future fertility, and therefore just looks for symptom-based management. What do we do for these patients? We provide a scrotal support and pain management with NSAIDs. Couple final questions on better differentiation of the high-risk features. 1, true or false, bilateral varicocele is a warning sign. That is false. Bilateral is not considered concerning, but right-sided or rapidly enlarging is considered a warning sign. Now, what are the differentials of right-sided varicocele? In addition to presence of a retroperitoneal mass, we could have thrombosis involving any of the renal or gonadal veins. Finally, you may be asked, what's the initial imaging and best imaging? Again, initial imaging is ultrasound, even for the right-sided one, but the best imaging is abdominal CT. Okay, this was our discussion of varicocele. Let's move to the other condition in association with mass arising from the spermatic cord, and that is hydrocele and hematocele. What are they mainly? They are presence of fluid or blood in the tunica vaginalis. Now, what factors in clinical picture help distinguish hydrocele, hematocele from varicocele? Well, varicocele more notably responds positively to Valsalva, though remember this is not a sensitive measure, because if hydrocele and hematocele have some connections to the peritoneal or intra-abdominal cavity, Valsalva may also enlarge the hydrocele hematocele. So the best mode of differentiation is that bag of warm appearance of varicocele versus the most important maneuver in physical exam, and that is transillumination, that is positive in this cystic or fluid-filled masses, the hydrocele, hematocele. Now, how do we distinguish hematocele from hydrocele? Both of them are a collection of fluid. However, hematocele means history of trauma to testis or scrotum should be present. What is the concerning possible complication in the case of hydrocele? If the hydrocele is large, or especially the congenital hydroceles, these could be associated with the risk of complication into torsion, as they impair the attachment of the lower testicular pole to the scrotum. Now, what is the management? It could be managed electively by surgical excision. True or false, the preferred management of hydrocele or hematocele is percutaneous aspiration. That is false. Why is it false? And this is perhaps the most important thing I would like us to remember. It's because percutaneous aspiration would result in recurrence. These are recurring. We need to address the pathology. Even though aspiration may help differentiate between hematocele and hydrocele, it is not therapeutic. Surgical excision is required for the treatment. Now, the question is, do all patients require treatment? No. Again, follow the same logic of management of varicocele. To some extent, we do not necessarily perform sperm analysis here, but if the patient has symptoms or any other concerns, the urologic referral for surgical repair is recommended. Otherwise, we can also manage the hydrocele, hematocele with observant management. Final question about the hydrocele is, what's the most common age? Most of them occur in the infancy as a congenital abnormality, and that usually subsides spontaneously. Okay, now let's turn our attention from the masses originating from spermatic cord to the masses that originate from epididymis. Again, we are not discussing the acute epididymitis here. The TCS, not the cells necessarily, the 3 previous cells were from spermatic cord, but this one here, we have one cell, and that's a spermatocele. We have epididymal cyst, and then we have epididymal appendage torsion. Now, what's the exact difference between epididymal cyst versus spermatocele? Both of them contain spermatozoids. However, the cyst is if the enlargement of epididymis is greater than 2 centimeters. If the epididymal mass containing sperm is smaller than 2 centimeter diameter, it's referred to simply as a spermatocele. True or false, the best way to differentiate spermatocele or epididymal cyst from hydrocele and hematocele is transillumination. That is false. Why is it so? Remember, these are again these fluid-filled masses, and therefore they can still transilluminate. So what's the best way to differentiate them? One is the location. Remember, in the acute epididymitis section, we mentioned that epididymitis occurs on the cephalon and posterior pole of the testicle. That's the area you need to develop some sensitivity on physical exam maneuvers. And the second is a response to Valsalva. We mentioned that the most responsive to Valsalva is varicocele. However, it is possible for hematocele and hydrocele to also be responsive to Valsalva if they are connected to the peritoneal cavity. However, it is for sure that spermatocele and epididymal cysts would not enlarge in response to the Valsalva maneuver. They do transilluminate, and they are located on the supero-posterior pole of the testis. What other factor favors the diagnosis? In physical exam, they are usually painless. Remember, we mentioned both hydrocele and varicocele could be painful. Now, what is the confirmatory mode of diagnosis? Aspiration with semen analysis of the aspirate. What you would see in the semen analysis of the aspirate, you would see cloudy, immotile sperms. We can also use ultrasound to differentiate them from other masses and fluid-filled cysts that we discussed so far. Now, what is the management? Remember, we mentioned that we do not manage hydrocele, hematocele, if symptomatic, with just aspiration because they recur. Here, the management could be aspiration alone. However, excision may be needed if the aspiration fails the treatment, or if the symptoms are severe enough to require surgical management. Okay, now let's turn our attention to our final topic of this episode, and epididymal appendage torsion, torsion of epididymal appendage. Now, what is the significance of this condition? You may think of it as a very uncommon condition, but that is totally wrong. Actually, epididymal appendage torsion is the most common cause of hemiscrotal pain in children. Hemiscrotal pain is caused by epididymal appendage torsion in children more commonly than any other condition. So that is the manifestation. A child with hemiscrotal pain, the pain is gradual onset. Remember what was the age for the testicular torsion? The age is usually the adolescence, and the onset was usually acute. But here it's more gradual onset, and we are usually dealing with a younger child. Now, what is the important finding in the physical exam especially the ones that can help differentiate it from the testicular torsion. One is the blue dot sign. There is a tiny blue dot on the area of the epididymis on the scrotum. That's referred to as the blue dot sign. And the second is the cremasteric reflex is not impaired as opposed to testicular torsion. Once more, there is this blue non-tender nodule at the head of epididymis that is visible on the scrotum. Yet another reason to be able to skillfully find the location of epididymis as a distinct mass posterior superior to the testicle. Now, that said, I'm returning now to the very first sentence that I mentioned in our acute testicular pains episode, and that was the need to rule out torsion. So if the patient has all these findings, true or false, the diagnosis is clinical and does not need further workup. That is false even in a child. Because we have scrotal pain in a child, we need to rule out torsion, and therefore we still perform Doppler studies. Final question of this episode: when the torsion is ruled out and we have this diagnosis of epididymal appendage torsion, what is the management? Management is supportive with NSAID, ice pack, and scrotal support. Remember, as usual, if the symptoms are refractory to these supportive measures, surgery could be considered. Quick review at the end: you have a mass in the scrotum. You need to first rule out the possibility of testicular cancer. If that is taken care of, we are dealing with the masses that arise either from the spermatic cord, such as varicocele, hydrocele, and hematocele. These usually respond to Valsalva, especially varicocele. The varicocele has the bag of worm appearance based on the presence or absence of warning signs, patient's preference, presence or absence of symptoms in the sperm analysis for sperm variables, or age of the patient. We manage it either with observation or supportive measures or ligation of the gonadal vein. Now, in the case of hydrocele and hematocele, if you have transillumination, they are not in the region of the epididymis. They may or may not enlarge with Valsalva. We can observe them, or we may consider surgical excision, but we never manage with aspiration alone. If the mass arises in the epididymal region, if it is painless and transilluminates, we may consider aspiration with semen analysis. That could also manage it. But if there is the blue dot sign and is painful, we perform Doppler to rule out torsion. And if torsion is ruled out, we are dealing with epididymal appendage torsion. And in that situation, we manage it supportively. So this is our discussion of chronic scrotal symptoms other than the testicular cancer.